For those of you, if you haven't met me, I'm Nancy Farraco. I am the chapter representative for our Charleston chapter here of the Bobby Jones Chiari Syringomyelia Foundation. And we usually start out with a patient experience lecture, but we don't have that tonight, so we're just going to start right out with Dr. Pocinki. I want to introduce Dr. Pocinki. He is a general internist in private practice in Rockville, Maryland, so he flew down to help us with this. He's been interested in the joint hypermobility syndromes and related autonomic and sleep disorders since the late 1990s and speaks regularly on these subjects at local and national meetings, including those of the Ehlers-Danlos Society and Dysautonomia International. His publications include co-authoring major articles on the evaluation and management of fatigue and autonomic dysfunction in Ehlers-Danlos patients, which were published in 2017. And he has received a variety of awards and recognition for service to his profession, as well as for the quality of his practice. He received his medical degree from Cornell University Medical College, and he's a fellow of the American College of Physicians. Welcome, Dr. Pocinki.
Thanks. Okay, so Nancy asked me to do this, and I figured I would focus on symptoms and management, and I think that's what people are most interested in. I could talk about pathophysiology and why we think people have autonomic problems, but this is going to run a little long depending on how much time we have. I have some case presentations to go through at the end. So, very basics. I am going to talk about some off-label uses of medications. I don't have any financial conflicts of interest because there's nobody who wants to financially support this work. So the autonomic nervous system, very basic. Autonomic nervous system regulates everything that happens automatically in your body. Heart rate, blood pressure, breathing, digestion, regulation of body temperature, all the things that fortunately you don't have to think about all the time. Your body's doing this. And when it's working well, all these things are regulated and you don't even notice it. But unfortunately, dysfunction is very common in Ehlers-Danlos, hypermobility spectrum disorder, and related conditions, and really underlies a lot of the symptoms that people have. So it's a little oversimplified, but helpful to think about the autonomic nervous system as a two-arm system, basically accelerator or brake. There's the sympathetic nervous system, the parasympathetic. The sympathetic nervous system is your fight or flight. That's your adrenaline stress response. Parasympathetic we call rest and digest. When you've eaten, you increase parasympathetic tone, and hopefully, when you go to sleep, you'll increase parasympathetic tone. And of course, the main job of the autonomic nervous system is to maintain stability, so that if you get a little cold, your body will warm you up. If your blood pressure gets a little low, your body will raise it back up again. If your blood sugar dips, you'll get it back up again. And in addition to that, to respond to stresses, so that if you exercise, your body will increase your heart rate and blood pressure appropriately. So when the autonomic nervous system doesn't work properly, it's characterized by instability, heart rate, blood pressure, body temperature, whatever, fluctuate, and a failure to modulate the response to stress. Stress happens and your body either doesn't respond to it at all or over-responds to it. Most often in patients who have these conditions, we find that the autonomic nervous system overreacts to minor things. So if your body temperature drops a little bit, instead of bringing it up a little bit, your body brings it up too much, and then you're too hot, and then you overcorrect, and then you're too cold. Or heart rate, blood pressure, the same thing happens. You get this overreaction, overcorrection, back and forth, what I tend to call the autonomic roller coaster. So what this looks like, without going into all the details of this, and I'll just, this is fairly old, but simple autonomic testing equipment that measures the parasympathetic and sympathetic activity at the same time. So I think you can just look at these two pictures and see the normal and the abnormal and see the problem. But common problem for folks, of course, is that, oh, can you guys see the pointer? It's pretty tiny. Okay. So during this part of the test, we have the person stand. So a normal, healthy person, when they stand, blood flow to the brain drops a little bit, and there's a little increase in sympathetic tone. Heart rate goes up a little bit, blood pressure goes up a little bit, so that you don't feel lightheaded when you stand up. That happens, that really just lasts, I'm having trouble. That really just lasts maybe 30 seconds, and then your body constricts some blood vessels and moves some blood from other places and so on, and you don't need that extra sympathetic tone to maintain blood flow to your brain. But if your autonomic nervous system isn't working properly, well, I'm having trouble finding this, but there it is. What happens is you stand, blood flow to your brain drops, and your body hits the gas too hard, and then almost immediately the pressure sensors in your neck say, wait a minute, now the blood pressure's going up too much, heart rate's going up too much, we better slow down. And you don't slow down like this, you suddenly slam on the brakes even harder, and whoa, that's too low, better hit the gas again. No, that's too fast, better hit the brake again. No, that's too much brake, better hit the gas again. And this person's been standing for 3 minutes, and her body's still trying to get her heart rate and blood pressure adjusted to maintain tone. So you can also see how this kind of autonomic dysfunction contributes to fatigue. This person's wasted a ton of energy just trying to keep from feeling dizzy when she stands up. So, as I said, I won't say a lot about this. There's a lot of different theories about why hypermobile people seem to be predisposed to autonomic problems. I'm particularly a fan of the stretch receptor theory, which is that there are stretch receptors, there are sensors throughout their body that detect changes. So there are stretch receptors in the artery in the neck that detect changes in blood pressure. And if there's a small increase in blood pressure, your body will make those corrections. But if your stretch receptors, like everything else, are stretchier than they should be, then your body may overreact to a small increase and then overcorrect and set this all off. So, how does this show up in terms of symptoms? Well, you can pretty much go through every organ system in your body that's regulated by the autonomic nervous system and say, well, what would go wrong if my autonomic nervous system weren't working properly? So most people who talk about autonomic dysfunction think about cardiovascular autonomic dysfunction, the big problem there being orthostatic intolerance. They're lightheaded when they stand up. Cold hands and feet, another symptom of poor circulation, palpitations, fluctuating blood pressure. Raynaud's phenomenon, I'm convinced, is primarily an autonomic problem. Heat and cold intolerance, if your body's not regulating temperature properly. If it's not regulating blood flow properly, then it's hard for you to cool off or warm up when you need to. But in addition to circulatory problems, gastrointestinal tract is regulated by your autonomic nervous system. So you can have everything from, if your sympathetic tone is high, if you're making adrenaline because you're exhausted and you're in pain, then your parasympathetic tone is going to be low. And the analogy I always make to that is, if you're doing the fight or flight thing and some wild animal is chasing you, you don't want to stop and have to go to the bathroom. So your gut shuts down as long as so there are big autonomic components to poor motility throughout the GI tract. You've already got a GI tract that's too stretchy, it doesn't contract well, but the autonomic piece is often overlooked. And then same thing, your bladder's under autonomic control, so if it's over-contracting or over-relaxing or won't relax when you want it to, then you'll have problems. If it relaxes too much, then you'll have problems at the other extreme. In the respiratory tract, same thing. Most often people, or more often people around them, will notice and say, why are you breathing funny? And you're like, I'm not breathing funny. And they say, oh, yes, you are, because something has triggered your respiratory rate to either speed up or slow down when it didn't really need to. And another common symptom, we have dyspnea, which is the sense that you can't get enough air in. And that has both mechanical components, autonomic components, and cardiovascular components. Adrenaline itself is a bronchodilator, dilates airways. Again, you're doing the fight or flight thing. You want to be able to breathe as fast as you can. Vestibular problems are very common. You see a lot of people who have problems regulating their balance. Again, that has many pieces. Unstable joints can make you feel unsteady. Lightheadedness obviously can make you feel unsteady. But your balance mechanism is also under autonomic control. So if you turn a little bit and your body overreacts as if you had turned too much, then you'll overcorrect back the other way and overcorrect back the other way, and then you're trying to hold on to something to steady yourself. I'll talk a little bit more about sleep because it's a huge factor. Autonomic dysfunction both contributes to poor sleep, and then poor sleep helps perpetuate autonomic dysfunction. Psychiatric symptoms are a tremendously overlooked thing, and there'll be an Ehlers-Danlos book coming out later in the year, and I guess coincidentally, I wrote the chapters on sleep problems and the chapters on mistaking autonomic symptoms for psychiatric symptoms. So clearly, if your body over-responds to stress by making too much adrenaline, that could easily be mistaken for anxiety or a panic attack. When in fact, it could be that your blood sugar dropped and you've got an adrenaline rush because of that. And I even saw 2 people just in the past couple of weeks who were misdiagnosed as being bipolar because people mistook the high adrenaline from fatigue and pain as hypomania. And ADD is another common misdiagnosis. If you haven't slept well, I heard somebody earlier say she hadn't slept well her whole life. If you haven't slept well, you're going to have trouble concentrating, you're going to have trouble focusing, you're going to be reluctant to start projects, you're going to have trouble finishing projects, you're going to have all the classic symptoms of ADD. And taking a stimulant is the last thing you want to do. So, won't spend a lot of time on this, except to try to clear up some confusion. So, lightheadedness on standing, or what we call orthostatic intolerance or orthostasis, is a very common symptom of autonomic dysfunction. Typically, we measure heart rate and blood pressure lying down and then on standing. Some people have you stand for 3 minutes. Some people think 5 is better. My friend Peter Rowe from Hopkins published a paper recently where they had people stand for 10 minutes and found that they found a significant percentage more people having autonomic problems who autonomic problems were not obvious at 5 minutes. Ansar testing is what I just showed you with the red and blue things. That's not particularly readily available, but it's a useful thing as an illustration. Tilt table testing I include for 2 reasons. 1, because it's what's generally recommended to evaluate orthostatic intolerance, and 2, because I think it's exceptionally cruel to say to someone, gee, if you're lightheaded every time you stand up, why don't we have you stand up until you feel like you're going to pass out or throw up? And I think this cartoon is a good analogy of asking someone who's complaining of vertigo to go through a revolving door. That's really not necessary. I have this Ansar equipment in my office and I hardly ever use it because I don't really need to. I can tell from patients' symptoms and from just the sitting down, standing up, change in their vital signs what's going on. So, again, I hate to do this, but I see so much confusion about these terms that I just want to put this out there. I really think this is confusing. The way these criteria are set up now is that there are specific criteria for POTS, there are specific criteria for orthostatic hypotension, and there are specific criteria for neurally mediated hypotension. If you don't have one of those 3 things, then you have orthostatic intolerance. Well, I'd say if you do have those 3 things, you also have orthostatic intolerance. But this is the way things are. Most of the people I see who've been told they have POTS don't really have POTS. As you can see, the definition of POTS requires a 30-point increase in your heart rate on standing without a significant drop in your blood pressure. As you might imagine, one day you might have a 30-point increase, and the next day it might be 25. So it doesn't really make it, well, gee, yesterday I had POTS, today I don't. That's not a particularly helpful label. I think just thinking of this altogether as orthostatic intolerance, or even more broadly as autonomic dysfunction, is more helpful than these specific labels. But these are the conventions currently. So, similar caveats apply to the other testing. So if you want to see whether autonomic dysfunction is a factor in your gastrointestinal problems, you might have motility testing or you might have a gastric emptying study. But your gastric motility, your whole GI motility could vary a lot from one day to the next. It can vary from 1 hour to the next. I've seen people who, wake up in the morning and their stomach is still full of dinner the night before, but on the day they had gastric emptying study, it was normal. And obviously it's not. So those things I don't find particularly helpful. Bladder function testing is really mostly helpful in looking for neurologic problems, specifically tethered cord syndrome, because there are lots of different causes of bladder problems, and if your bladder function, your bladder dysfunction is a pattern that looks like it's neurological or what we call neurogenic bladder, that's more concerning for tethered cord. What I see very often is that pelvic floor problems are mistaken for bladder problems. If you have an unstable pelvis, your pelvic floor is going to be tight. Your pelvic floor muscles are going to be tight trying to support your pelvis. And if then you decide, well, okay, gee, I need to go to the bathroom, I need to pee, pelvic floor, please relax. Your pelvic floor might say, yeah, no, we can't relax. We're holding the rest of the body up here. So I see a lot of people whose bladder dysfunction actually is related to pelvic floor dysfunction because of chronic pelvic floor spasm. Pulmonary function testing occasionally can be helpful. I really, again, you can tell I'm not a big tester. What I see most often, people have pulmonary function tests, is they're misdiagnosed as having mild asthma because it looks like they have some obstructive symptoms, meaning when they try to breathe out, their exhalation is delayed a little bit, not because their airways are inflamed in asthma, but because their airways are lined with overly stretchy connective tissue, which when pressure is put on it, collapses more than it should. And a lot of people, I was diagnosed with asthma, but those inhalers never helped me at all. It's like, well, that's probably because you didn't really have asthma. And then diagnostic testing for sleep is very helpful to figure out what's going on and to guide treatment of sleep problems, and I'll talk some more about that in a minute. So this is what a normal, we call hypnogram, looks like. These are sleep stages through the night. So most people fall asleep, spend a little time in shallow sleep, then get a chunk of deep sleep, shallow, REM, shallow or light sleep. Most people get a little more deep sleep here, but believe me, it's hard to find a normal. REM, shallow. So you see there's a fairly regular cycle here with most of the deep sleep early in the night. This is a typical pattern, what we see when somebody says, doesn't matter how long I sleep, I still wake up tired. I'm not having trouble breathing, I'm not having wild nightmares, I'm not thrashing around all night, but I wake up in the morning feeling like I haven't slept. And you can see, this person has a tiny bit of REM, no deep sleep. What you can't see here is that in the sleep lab, we define an awakening as a disruption to the continuity of your sleep that lasts more than 30 seconds. Most people need to be awake for 2 minutes to remember having been awake. So this person remembered having woken up twice. She actually woke up 23 times. If the continuity of your sleep is broken for less than 30 seconds, we call that an arousal. She had 125 arousals. So her sleep was disrupted 150 times. She only remembered 2 of them. And unfortunately, this was read as a normal sleep study by a board-certified sleep doctor, because this is not a pattern that's recognized anywhere else. So after seeing these for a while, I thought, well, I'm going to have to figure this out myself. And if you see, and the clue is here, that if you look at the patient's heart rate, at the same time you look at sleep stages, you could take a ruler and you'd see that every one of these little spikes lines up with an awakening. You also see the second most common pattern we see in patients here. The first person spent the whole night in shallow sleep. This person is trying to get into deep sleep, but you can see that every time she does, she just comes right back out of it. Here she just gets in deep sleep, back in shallow, tries to get deep sleep, back in shallow. She just can't get any deep sleep. Unfortunately, sleep lab software will add up all these little bits and might say that she spent 10 or 12% of the night in deep sleep when really she didn't get any deep sleep. And this is just a slide to show that this person, for whatever reason, her heart rate was nice and calm for about an hour. Her autonomic nervous system was calm and quiet, and so she got a decent, almost interrupted chunk of deep sleep. The rest of the night, again, if you took your ruler, you'd see that every one of these little spikes lines up with an awakening, one of the 25 awakenings that she had all night. So the overall goal in trying to improve autonomic function, I'm going to skip ahead because I think it's easier to do this with a picture. This is an oversimplified schematic or analogy, but I find it helpful to tell people, okay, if you think about having your own energy supply, you've got your own gas tank, and typically sleep is your chance to put gas in the tank. You're not running around, your brain's not using energy, your body's not using energy, you're recharging your batteries so you get up in the morning, you can do stuff. If you don't sleep well, clearly you're not putting gas in the tank. If you're in chronic pain, pain is sucking up energy. If you're exhausted but you're fighting through it, you're depleting your energy reserves. If you're dehydrated and every time you stand up your blood pressure drops, then again you're doing that thing with the sympathetic nervous system and you're wasting cognitive effort. People don't realize you try to read, your brain's drawing from that same energy pool that your body would be drawing from if you tried to walk up a couple flights of stairs. Emotional stress sucks up energy. Work things, school things, And DC political stress is a big factor for a lot of people. And so the basic paradox of autonomic dysfunction, these syndromes, is that the more depleted your tank gets, instead of feeling more and more and more exhausted, you actually get more and more jittery. So the little bit of energy you have will try to keep you going. But in that scenario, you lose your ability to modulate stress. Everything becomes a big deal. And your body overreacts to trivial things. And this is, I see heads nodding. Spouses recognize this. It's like, yeah, and I have to say, yeah, there is a reason why she makes a big deal out of little things. Then she's right, she can't help it. It's not a psychological thing, it's a physical thing. So the goal of trying to improve autonomic function is to say, okay, how can we replenish the tank? And so obviously it's the reverse, trying to improve the quality of sleep, optimally manage pain, rest when you're tired, don't push through it, don't hit the Red Bull or the Diet Coke and try to keep going. Make sure you're adequately hydrated, and their common problem that I see is even people who are told to eat lots of salt and drink lots of water are not getting enough salt and are getting too much water. So have some more salty snacks when you go. And then sort of, budget your energy, do a little bit of rest, and I think that's pretty much what the previous slide had said. Yeah, I guess the only thing other to mention here is the idea of pain control, and that most people who are in chronic pain get used to being in pain and don't even think about taking something for pain unless what they're feeling is substantially above the level of pain that they're used to. And trying to bring down that level of what I call background pain can really make a difference in sleep and energy and mood. I think I have a slide about that later. So, orthostatic intolerance, how do we make that better? So obviously, if you're lightheaded when you stand, try not to stand up too quickly, try not to stand too long. Exercise will help because the better your muscle tone is, the less of your circulation is pooling, the less of your circulation is just sitting around in these overly stretchy veins that you have. Adequate salt and fluid, I mentioned, trying to limit or stay away from alcohol, caffeine, any kind of medications that take fluid out of your system are going to make this worse. If you have to stand, compression hose really help and are, not as ugly as your grandmother's support stockings used to be. You can get compression hose that really look like leggings. Licorice is something that people have used for, decades is probably fair. About a century ago, people discovered that licorice has a chemical in it that actually increases blood pressure. And so now most licorice-flavored candies and so on have that chemical called glyceric acid taken out. But you can get raw licorice or non-deglycerized licorice, which some people, I saw a woman years ago with the adrenal insufficiency who was medicating her own adrenal insufficiency with about 100 licorice capsules a day. And then the prescription version of that is fludrocortisone or Florinef, which is a synthetic version of your body's natural salt and fluid retaining hormone. So in addition to trying to sort of beef up your circulation, the other thing we want to try and do is get you off the roller coaster, not waste so much energy, avoid the palpitations, avoid the spikes that are disrupting your sleep. So as much as you can, avoiding stresses that are going to drain the energy, making sure your pain control is really where it should be. Then medications like the stimulants and midodrine constrict blood vessels, raise heart rate, raise blood pressure. People who are chronically lightheaded and chronically low blood pressure, those can be helpful. I'm not a huge fan of midodrine because typically only lasts about 3 or 4 hours, and this kind of thing is exactly what we're trying to get you away from. but some people do find it helpful, or find it helpful for occasional use. Again, if they know they're going to have to be on their feet for a while, and being on their feet for a long time makes them dizzy, then taking midodrine beforehand can be helpful. But if you think about the roller coaster that I showed you earlier, what midodrine essentially does is raise the floor. So you go up, down, up, down, up, down. You don't drop quite as far. So I'm more of a fan of medications like beta blockers and clonidine that block that initial surge that starts the roller coaster going. And then ivabradine is an interesting drug that lowers heart rate, blocks heart rate increases without affecting blood pressure. So some people who have orthostatic hypotension or orthostatic intolerance, if you give beta blocker to block their heart rate, you can lower their blood pressure a little too much. I rarely see that. That's more of a theoretical concern. But ivabradine has found a niche for people who truly do have POTS, whose heart rate goes up, but their blood pressure doesn't. So other things a little bit more indirectly helpful in managing cardiovascular autonomic problems, particularly in teenagers and college-age women. There's a decent amount of data that birth control pills can help. I can't really explain to you why, but a lot of people do find that helpful. Pyridostigmine is a drug that's used primarily to treat myasthenia gravis, but it increases parasympathetic activity. So you can use a beta blocker to block your sympathetic, and you could use pyridostigmine to raise your parasympathetic, or some people maybe even do a little bit of both. Serotonin reuptake inhibitors, or the SNRIs, serotonin is one of your calming neurotransmitters, so it can help with the jitteriness that people get. The important thing here is you're not treating anxiety or depression, and most people need smaller doses than what we use for anxiety and depression. The norepinephrine reuptake inhibitors are helpful because they can sometimes raise blood pressure. They also have effects on fatigue and pain as well as on mood. So there are a couple of those that are specifically approved for pain as well as their effects on anxiety and depression. Desmopressin is a drug designed for children with bedwetting, helps to retain salt and fluid. And butcher's broom is centuries old. It's called a venotonic. It supposedly helps reduce the swelling of things like varicose veins and hemorrhoids. That if your veins are swollen and too much blood is sitting there or pooling, it supposedly works that way. I can't tell you that I've ever seen anybody who had a dramatic response to it, but I include it for completeness and because some people don't do well with prescription drugs, and there are often herbal options. So I often start by reminding people that, as Nancy said in her introduction, I'm a clinician. I sit in the office all day. I don't have a team of grad students and fellows and researchers, and I don't, and I didn't figure this out by reading papers or textbooks or talking to my colleagues. I learned this from my patients who said, gee, I wake up in the middle of the night with my heart pounding and racing and crazy thoughts going through my head. And I said, gee, that sounds like too much adrenaline. And I started putting people on beta blockers, and this is what they told me. I'm stunned, amazed, and grateful at the benefits of taking propranolol. Improving my sleep alone is fantastic. Medicine you gave me is amazing. 2 worked great, 3 worked even better. I forgot to take it one night. I slept 12 hours. I felt terrible. The next night I took it and slept 6 hours, and I felt great. Another patient I've known for years said, metoprolol seems to help with my sleep. In fact, between metoprolol, cyclobenzaprine, and ibuprofen, I can fall asleep, I can stay asleep, and the metoprolol in particular seems to be important for improving the quality of my sleep. And in some cases, we have data from people's home sleep monitors showing that we can see the number of disruptions before and after treatment and say, okay, you're not imagining this really is working. So this is somebody I just saw last week who said, it's amazing how much getting my pain under control has helped my dysautonomia. And this is the idea of background pain. I knew I was in pain, but all my doctors had told me, use as little pain medicine as possible. I said, no, you're in pain all day. That's why you're exhausted. That's why you can't sleep well. That's why you're depressed. That's why your autonomic nervous system can't work right. So getting her pain under control made a huge difference. So autonomic nervous system, unfortunately, regulates everything that's going on. Autonomic dysfunction is very common in Ehlers-Danlos and typically characterized by this overreaction to something minor and then overcorrect and then back and forth, the roller coaster. Problems with sleep, I think are largely caused by autonomic dysfunction, and then getting a crummy night's sleep and waking up exhausted, then you've got to kick in some adrenaline to keep you going through the next day, and then you don't sleep well the next night. So I think poor sleep plays a major role in perpetuating autonomic dysfunction. So overall, treatment is aimed at replenishing the pool, reducing the fluctuations, minimizing stressful stimuli, and replenishing the tank, restoring the balance, minimizing daytime stresses, minimizing fluctuations that are wasting energy during the day, improving your sleep is how people get better. So thanks. I'm hoping we have time. I'm going to go through a few sort of illustrative cases because make this a little bit less theoretical. And I guess thanks to Nancy and the chapter for inviting me. I always thank some of my colleagues who encouraged me 15 years ago when everybody else thought this was crazy. And of course, I thank my patients because they're the ones who helped me figure out this stuff and were willing to let me experiment on them. I said, this makes sense to me. What do you have to lose? So this is a guy came to me for about 18 months. He'd been having episodes of lightheadedness at work. He would typically in the middle of the afternoon, he would get lightheaded, and his colleagues would find him lying on his back on the floor next to his desk. And then say, well, what's going on? And he said, oh, it's okay. It'll pass. This happens all the time. Don't worry about it. But after about a year and a half, eventually a couple of his friends prevailed upon him to go to the doctor. So he said, well, I wasn't just standing up. Usually I was just sitting at my desk, and I would just suddenly get, whoa, I better lie down. And he'd lie down, and 10, 15 minutes would pass. He would say, yeah, I felt a little weak. He felt kind of weak all over. He felt nauseous. He felt dizzy. His vision would kind of gray out a little bit. He had this sense of what he called jamais vu, where he was like, he said, I should recognize where I am, but I don't really recognize what's going on. Lying down would help, but would still take quite a while for it to completely go away. He said it actually happened 5 years earlier after an acutely stressful event at work, but recently have been getting much more frequent. So, and in asking a bunch of other questions, he said, yeah, somebody once had given him albuterol, and it caused an extreme reaction with EKG changes. So, and while I was trying to talk to him, he kept saying, just be quiet for a minute so I could focus. He was a short, pretty stocky guy, so not somebody you would have looked at and expected to be hypermobile, but in the joints of his hand, you could see that he really was hypermobile. So, unfortunately, he came to me with a stack of records like this. He'd not only had a 24-hour heart monitor and an echocardiogram, he'd had an event monitor, which was a 30-day thing, and then when that didn't show anything, he had a surgically implanted heart monitor because somebody was convinced that he was having irregular heartbeats. He had a stress test to make sure he didn't have coronary disease, and when the stress test was negative, he had a coronary catheterization to make sure he didn't have coronary disease. So I said, well, gee, this sounds to me like an autonomic problem, and it sounds to me like what I call depletion. Your tank is empty, and just sitting in one place, people say, well, I wasn't really doing anything, I was just sitting there. Well, sitting in one place is really almost as bad as standing in one place. It's really hard on your autonomic nervous system to maintain blood flow to your brain when you're not moving and keeping blood flow going. So I said, usually this happens, I see this in people who are either in chronic pain or people who don't sleep well, or both. For some reason, your tank is empty. So he said, no, he didn't have pain. I said, well, you have trouble sleeping? And he said, no, not really. He said, usually it takes me a while to fall asleep, and then I'll sleep for a couple hours, and then usually I wake up, and I'm usually up for a couple hours, and then I'll go back to sleep for an hour and a half, maybe two. I said, well, how long has this been going on? I said, sounds like you're getting 3.5, 4 hours of sleep. He said, yeah, I guess so. I said, how long has this been going on? Yeah, 15 years. I said, okay, so I think this is an autonomic problem. So I said, here's what's happening. You sit for a while, blood flow to your brain is gradually dropping until it gets to some critical point where suddenly your body panics and you go whoosh, whoosh, and your blood pressure shoots up and then it drops. And you just need to take a beta blocker so that big up doesn't cause the drop, and then hopefully you won't be dizzy. And this was quite a while ago, and my fingers were crossed because I still wasn't convinced that these theories of mine were right. So I started him on a long-acting propranolol twice a day, kept my fingers crossed, and kept waiting to hear back from him. I didn't. Came back a month later. I said, well, what happened? Did the medicine work? He said, oh yeah, as soon as I started taking it, I didn't have the spells anymore. So I said, okay. Unfortunately, the sad epilogue to that is then I sent a note back to a couple of the cardiologists he'd seen previously explaining exactly what was wrong with him. I never heard anything more from them. They were not interested. So this is a 35-year-old woman, came with a diagnosis of chronic fatigue syndrome. And she said she was just exhausted all the time and had been for years. She spent most of the day lying in bed or on the sofa. She was too weak really to do anything. Her husband would do everything for her, and she was basically unable to leave the house. Pretty sad at 35. And she was literally, her husband dragged her in with the fireman's carry. She was like this, and he dragged her into the office. She looked pale, she was lethargic, I couldn't, all these nasty things we do to people. We mash on their fingers, we mash on their breastbone. Couldn't get her to come around. Her blood pressure was 60 over 30. Her heart rate was 60. So right away, you know something's wrong with your autonomic nervous system. When your blood pressure drops, the first thing your body does to correct for that is raise your heart rate. So eventually, and it was a long 10 minutes before she started to come around. So I tried to explain to her and her husband that the only way that, given that, unless she had something rare like adrenal insufficiency, the only way that her blood pressure and heart rate would be that low is if they went up too high and then came crashing down. I said, this doesn't make any sense to you, I know, but I want you to start taking a beta blocker to block that crazy up and down, and hopefully that's going to help. So I started on a very small dose of something called the beta-lol, and I said, keep increasing your dose until you can stand up without feeling dizzy. So she ended up on 200 milligrams 3 times a day, 600 milligrams a day, which are a pretty big dose. Again, what I mentioned earlier about beta blockers could theoretically lower your blood pressure, but in these situations they don't. And she felt much better, and she was actually up and around and getting around the house, and even being able to do a lot of stuff she hadn't been able to do in years. She came back again a few months later, and my office, after she left, my office manager said, I can't believe that's the same person. And I saw her recently. She's still on a smaller dose of labetalol, running her own business, working long days, 7 days a week. She's doing great. This is probably one of my biggest surprises. A 21-year-old woman, completely healthy. I'd seen her year and a half earlier for a routine physical. I think she had forms for college or something I needed to do. Her blood pressure was 110 over 78, about what I expect for a woman that age. She came in complaining of fatigue, said she hadn't been sleeping well. And I asked her a whole bunch of questions, and then I examined her. And her blood pressure was 180 over 120. And I was shocked. And I was like, and I took it again. And I was like, okay. And I looked for signs of the hyperthyroidism. I asked her questions about any other medical conditions that might explain this. And there are other, rare conditions. There's something called, what's the name of it? I'm blanking out. Fibrosis of the renal artery that we see. But that wouldn't explain this big a change in blood pressure in such a short period of time. So there really was nothing to go on. Fortunately, she also looked for signs of damage from high blood pressure behind the eye or hyperreflexia. Fortunately, didn't have any of those things. So I said, this has got to be what people call a hyperadrenergic dysautonomia. For some reason, you're either exhausted, you're dehydrated, there's something, and your body's just cranking out adrenaline to keep you going. So I explained this to her and her parents. They were skeptical. I said, fine. They went to see the cardiologist. The cardiologist did an echo. The cardiologist did a renal artery sonogram to look for renal artery stenosis. They did a whole bunch of blood tests. They tested for pheochromocytoma to make sure she didn't have an adrenaline-secreting tumor. Well, that came back normal. The only thing that was abnormal was she has slightly elevated aldosterone. Aldosterone is the hormone that retains solid fluid. So that was not surprising to me, because when I see people with blood pressures this high, they're almost always vasoconstricted. So I just saw somebody in the office yesterday with a blood pressure of 180 over 115. You would think with blood pressure that high that their pulses would be really strong and they might even be flushed. No, her hands and feet were cool and her pulses were faint. So these people are really constricted. So I said, she needs more salt and fluid. This is paradoxical, but that's why her aldosterone levels are high. But then they sent her to the endocrinologist, and she had this test and that test, and everything came back normal. So I started on a beta blocker. The cardiologist added another blood pressure medicine. She came back, her blood pressure was fine, she was feeling much less anxious, surprise, surprise. Her palpitations were gone. She still wasn't sleeping great. 2 months later, she came in, she'd had to cut back on her medication because as she started feeling better, the blood pressure medicine was making her blood pressure too low. Then I happened to see her again on spring break after a week of, shall we say, partying too much, and her blood pressure was back up again. And last case, I was going to share with you, is a 60-year-old woman again, talked about the overlap of the various syndromes. Oh no, I think I have two more. I think I have one more after this. So some clearly hypermobile, one woman with a diagnosis of chronic fatigue syndrome. This woman had a diagnosis of fibromyalgia, which in my experience is also hypermobility related. So she had a bunch of medical problems, pretty long history of not sleeping well, and the typical cycle of fibromyalgia, chronic pain, poor sleep, fatigue, depression. But her blood pressure had recently gone up significantly. So one of her other doctors found her blood pressure was high, sent her to the cardiologist. The cardiologist put her on one blood pressure medicine, then another blood pressure medicine, then a third blood pressure medicine. Turned out that she had something called normal pressure hydrocephalus, and that's why she wasn't feeling well. So that eventually was sorted out, and she got a shunt for that. And I saw her 6 months later, and she told me she was doing well, but her blood pressure was still high, and she was still on 3 different blood pressure medicines. So I talked to her for a while, and I said, I hate to tell you, but I don't think you're doing so well. I said, I think you're still depressed, I think you're still in pain, you're still not sleeping well, you're still tired. And I examined her, she still had a lot of pain. So I said, I think what's happening is this is just sympathetic, your body's making adrenaline in response to fatigue and pain, and that's what's keeping your blood pressure up. So there might be something else going on too. So we did her testing, and it looked like, sure enough, that's what was going on. So I said, I think the diuretic you're taking is making the whole thing worse. What happens when you get dehydrated? Your body's response to dehydration is to increase your heart rate and dump in more adrenaline, raise your blood pressure. So I took her off her diuretic. I said, go home and eat a bunch of salty food. I took her off the amlodipine. How does amlodipine work? It dilates blood vessels. If you take a medicine that dilates blood vessels, there's a reflex increase in sympathetic tone. To try your body senses your blood pressure is dropping, it raises your heart rate to try to compensate. So I took her off the one, I cut the other one by 2/3, and I started her on a tiny dose of beta blocker. She sent me an email 3 days later saying, you rock. I started the beta blocker 3 days ago. My blood pressure is 120 over 80. I've slept better than I have in 20 years. And I saw her subsequently multiple times, and her blood pressure was normal. So the moral of some of these cases is why. So somebody comes in with something that doesn't make sense. Their blood pressure's high. Don't just give them blood pressure medicine. Try to figure out why is their blood pressure high. If you're in pain, obviously you want to know why you're in pain and treat the underlying cause of the pain, not just take a pain pill. I know that's not the experience that a lot of you have. In the last case, this is somebody who really did have POTS. And I see a lot of people with orthostatic intolerance. I see very few people who really have POTS, but this was a guy who did have POTS. This is a DC person, worked as a chief of staff for a congressman, worked 14, 16 hours a day. Typically would sleep 4 hours. He went on vacation with a bunch of friends, and hip waders waded out in the middle of the river fishing. Suddenly he realized he wasn't going to make it back to shore. He was woozy, he felt like he was going to pass out. Fortunately, his buddies were nearby. They dragged him to shore. They had him lie down and made him go to the doctor. So here's what his testing looks like. And just remembering the first one, I mean, literally when he would stand, still trying to get this pointer, literally when he would stand, the adrenaline surge was just off the scale. And he essentially had his foot on the gas, all the way down the gas, and all the way down the brake at the same time. He was just exhausted and just pushing through it. So this is POTS, and here's what you see with heart rate. So that initial huge spike that you would expect, but then his heart rate, which started off at about 84, leveled off between 115 and 120. So more than 30 beats a minute necessary. His blood pressure didn't drop. But we know from his symptoms that eventually his blood pressure would drop, because he stood out in the river in one place for long enough. Eventually he got faint and almost passed out. So I explained to him what was going on, and I said, look, you're just totally exhausted. You don't realize you can't keep pushing through this. You're going to crash. I said, you need to get more rest, you need to get more sleep, you need to take breaks during the day, you need more downtime. He would get up at 4 in the morning and go to the gym, and then I said, you got it, you have to, you can keep exercising, but not so strenuous. Never saw him again. Clearly that was not what he wanted to hear. So I'm there, happy to take questions. It's a lot, that's confusing, a lot of it's paradoxical, I know. In fact, the last talk I gave here, I subtitled A Panoply of Paradoxes, because basic things like, why is it the more tired I am, the harder it is to sleep? Why would I take a medicine that lowers my blood pressure so that my blood pressure doesn't get too low? Yes?
If I were to swallow a couple grams of salt a day as a pill, could increase your salt. Is that equivalent to dietary better?
I'm not a big fan of salt tablets, and this is, again, probably very oversimplified, but my feeling is, and I have a paper that I'm trying to put together and finish that shows that a lot of people who are told to eat salt and water aren't getting enough salt. So I think, like I mentioned this business with this person who had the high aldosterone level, I think people who are lightheaded, their bodies are trying to hold on to salt. They're doing lots of different things to try and hold on to salt. If you suddenly dump in a whole bunch of salt all at once, your body may say, there's plenty of salt around. We don't need to be doing this, and this. And then the extra salt from the salt level goes away, and then it's, we need more salt. So I'm not a big fan of salt tablets. I'd rather you get dietary salt and drink electrolyte drinks and salted water and stuff like that, rather than taking salt tablets. Just my personal opinion. Yes?
I have two questions. The first one is, I was diagnosed with ADHD, and I went to like a clinical psychologist and did cognitive testing and all that. How do you know if it's really, you said ADD was one of the things.
Right, there certainly are people who have all these things that unfortunately have ADD also. This is way oversimplified answer, but I find that if you're somebody who tends to have trouble concentrating and be sort of jittery, and taking stimulants makes you feel calmer, then you probably really do. If you're exhausted and you can't concentrate because you're exhausted, then taking stimulants will just make you tired but wired. You'll just be exhausted and even more jittery. So may not hold true in every case, but yeah, I just saw somebody the other day who clearly has ADD. Her psychiatrist is afraid to put her on stimulants because it's afraid it'll make her anxiety worse. And she says, no, every time I take stimulants, I feel calmer. But yeah, so it's tough. And I actually do have a couple people who really are bipolar in addition to all this. And that's really tricky too.
I had another question.
Oh, sure.
Okay, so who do we go to for treatment?
So,
what kind of doctor are we seeing?
right, yeah, so this is the problem. I mean, there's nobody, even in the DC area, there's nobody really interested in seeing people with autonomic problems. And I think, last year, did I do the chronic pain, poor sleep, fatigue, depression talk?
Sleep.
Oh, I did sleep, right, okay. So one of my more popular talks over the year is on, what I call breaking the cycle of chronic pain, poor sleep, fatigue, and depression. And the problem with our system is the doctor who treats your pain doesn't feel comfortable prescribing antidepressants, which makes no sense to me because chronic pain and depression go hand in hand. Certainly the psychiatrist who's treating depression doesn't feel comfortable prescribing pain medicines. Neither one of them knows anything about sleep. And then your primary care doctor who may be evaluating your fatigue may not be comfortable prescribing pain medicines and antidepressants. And so you often have to be your own general contractor, or as I heard somebody say earlier, take something in with you to your whoever your primary care person is or whoever is coordinating your care to say, hey, I really think I read this stuff and I watched this video and I think these other symptoms are really a big part of this. Can you help me manage this too? But it's a huge problem. I mean, I see people who've been misdiagnosed and mistreated all the time.
Okay, I've heard a lot of people who have trouble regulating their temperature. Not putting much effort, and then they're sweating profusely and hot flashes, or then they're really cold. Does that have to do with the autism?
Yeah. Body temperature dysregulation is one of the really more frustrating symptoms of autonomic dysfunction because we really don't have the medications to help with it. There's this biofeedback device called the Ember Personal Thermostat, I think, that I've heard a few people say it was helpful. I'd have to say the majority of people who've tried it didn't think it was helpful. But yeah, it's the same idea, and it ties in with the circulatory dysregulation that, you know, if you're warm, your body will send blood to the surface to cool you off. But if it sends too much blood to the surface, then there's not enough going, then you can be lightheaded. And the other thing I need to add to that, to the graphic slide with the gas tank and the little things, is mast cell dysfunction, because we see that more and more often. And if your mast cells overreact to a minor stress, one of the things they make is histamine. One of the major physiologic effects of histamine is it makes fluid leak out of the blood vessels into the tissues. So then blood flow to your brain drops, and your autonomic dysfunction gets worse. So yeah, the body temperature thing we don't have. I mean, it's, you know, it's hard. It improves if, you know, if everything else gets better. Then that tends to get better. Susan.
It's something that, like if I have a patient who has like feelings of anxiety and heart palpitations, but then they take Benadryl and that kind of calms everything down. Then you're kind of looking at the histamine side of things, the mast cell, and it works.
Yeah. Yeah, right. So it seems to be a well-kept secret that the same histamine that makes your eyes itch and your nose run and makes you wheeze and makes your skin flush and makes your stomach growl is a very stimulating neurotransmitter. So it's essentially like adrenaline for your brain. So the reason that Benadryl makes you sleepy is because it gets into your brain and blocks histamine. And the newer generation antihistamines, Claritin, Allegra, Zyrtec, Xyzal, are specifically designed not to get into your brain, so they won't make you sleepy. But I pretty often see patients with mast cell problems who are having trouble sleeping, and I'll say, well, let's see, you're taking a H1 blocker like Zyrtec to block the histamine in your respiratory tract and your skin, and you're taking an H2 blocker like Pepsid to block the extra histamine in your GI tract, but the extra histamine is running around your brain unchecked. And occasionally I've been fooled. There are people that I've tried putting on several different beta blockers for sleep, and only when a few different beta blockers didn't work, I'll say, does Benadryl make you sleep? Can you take Benadryl, okay? The woman said, oh no, I can't take Benadryl, it knocks me out.
So yeah, I've had a patient who's been thrown a lot of different anxiety medications and still can't get, you know, they keep...
One of my favorites is hydroxyzine. Hydroxyzine actually is indicated for the treatment of anxiety. It's a CNS, it's a centrally active antihistamine like Benadryl. It has anxiety effects, it has pain effects, it has anti-nausea effects, it's sedating. It's a great thing for skin itching. That's, I'm every time people ask me about it, it's like, yeah, I guess I do have so old-timey medicine that, you know, totally thrown out when the newer generation of antihistamines came out. But it's incredibly safe. I mean, people take 25 to 50 milligrams at night. The maximum daily dose is 100 milligrams 4 times a day for the treatment of acute anxiety. So it's really safe stuff. If you take a lot, it just makes you sleepy.
And is it okay to take Benadryl every night?
Yeah. So there are some studies showing, there have been some studies showing some cognitive impairment. The big concern I have with Benadryl is next morning hangover. The hydroxyzine is a little more consistently a 6-hour drug. And a lot of people, especially Benadryl, don't realize that they're still impaired in the morning, and that's a problem. Also, there's a sizable number of people who have paradoxical reactions to Benadryl. I mean, they know that. They say, I can't take Benadryl, it makes me hyper. Doesn't sedate me at all. That doesn't necessarily mean that other antihistamines are going to have the same effect. But there was a study recently where they found a lot of people taking these over-the-counter sleep remedies night after night after night for years, and they said, well, gee, this probably isn't such a good thing. And they said, these people do have some cognitive impairment compared to other people who haven't been doing this. But of course, that's an unfair comparison group because not sleeping well can cause cognitive problems too. So I say, you have to take a group of people who don't sleep well and put half of them on antihistamines for 5 years and have the other ones get a crummy night's sleep every night for 5 years, and I bet the Benadryl people will be functioning better. So it's, potential risk versus potential benefit. Yes?
I have a daughter that has been treated for Lyme disease and takes a lot of sleep medications and antidepressants and all for pain. And when she sits or stands for any period of time, she has a lot of neck and shoulder pain still, even though the Lyme seems to be out of the way for now. But she swears that Zyrtec helps with her pain, so that would be the same type situation.
Yeah.
She still can't sleep well, she never feels rested.
Yeah, I mean, this is one of those, everybody's neurochemistry is different. I actually just saw a patient, I just heard from her earlier today. Her H1 and H2 receptors are reversed. She takes Zyrtec for GI problems, and she takes Pepcid for skin itching, and her dad has the same thing. So different people's receptors are different. So yeah. And there are H3 receptors in your brain, but yeah.
Do you treat peds?
Do I treat?
Pediatric.
No, I don't.
Do you know anybody who does? You would recommend? 5 and 3?
Yeah. No, I mean that, right? Because again, where do you start? If you go to somebody who really specializes in dysautonomia, they're not going to get the pain parts and the sleep parts, and the guy who runs
We have all of that, but we just don't have doctors.
guy who runs the Dysautonomia Center at the University of Maryland requires that everybody stop all of their medications before their initial appointment so they be tested. And it's like, no, you don't understand. These people can't stop their pain medicines. They can't stop their antidepressants. This just doesn't make sense. So, I mean, I share this frustration. We have people call in the office every day. There's only so many people that I can see, and part of the reason I do things like this so that people can maybe go back to their physicians with some new ideas. Yes?
Do you ever use cromolyn sodium?
Mm-hmm. Sure.
And how do you typically use that? I had my immunologist recently gave it to me, but he was not specific about whether or not to take it just during what appears to be some sort of histamine.
So he gave you cromolyn in little vials?
Yeah.
Okay, so cromolyn is a mast cell stabilizer. That's all it does. So it doesn't block histamine. It doesn't really do anything else. And for some people, it's much more effective than others. Typically, cromolyn is most effective in preventing GI-related mast cell symptoms. If there's somebody who has lots of apparent food allergies, but if you look at the list of high histamine foods, you're like, those seem to be the things I'm allergic to. Usually, you dose cromolyn about a half an hour before meals. Most people don't remember to take it half an hour before they eat. So say, well, if you're about to eat, oh gee, I forgot to take my cromolyn, take it, wait 5 or 10 minutes, and then eat. Some people add a dose at bedtime, especially if they tend to wake up overnight with heartburn or wake up overnight with an upset stomach. If one dose doesn't work, try 2. The maximum dose is usually 2-4 times a day. And I have a few patients, 1 did nothing and 2 does seem to work. But occasionally I see people who it makes their symptoms worse, but most of the time it either really helps or does nothing. It's not systemically absorbed, it's a purely local effect. So there's not a lot of downside except for the hassle of carrying these things with you and having to mix them with water to drink them.
So is it a medication that you have to take continuously for it to be effective?
Well, it's interesting, but the mast cell dysfunction in many patients tends to parallel the autonomic dysfunction in the sense that the more overtired, run down, stressed out, depleted you are, the more your mast cells are tending to overreact. And that if you get your pain and your sleep and other issues under control, or even if you get your mast cells to calm down for a while with medication, you may then be able to gradually cut back on your medication. So it's not necessarily because, the converse, the oldest person I ever saw develop mast cell activation disorder was 73. And I was like, how do you suddenly get this at age 73? I'd known the guy for 20 years. I was like, well, this is kind of weird. I have somebody in my own practice to us, this is, and this was 10 years ago. This was in the early days of mast cell dysfunction. And he went to Hopkins. They didn't know what to do for him. Went to Mayo. They didn't know what to. I said, I really think this is what this is. And he was on, we actually had to put him on Lyrica because when his mast cells would do it, his skin would sting and burn. It wouldn't just fletch and itch. It was really painful, but he was much better in about 3 or 4 months. And then, thinking that he was better, he called me up and said, I don't know. Turned out he'd eaten a whole box of strawberries. Strawberries are really high in histamine. So, but that was several years ago. He's been off any kind of mast cell medication for a long time. We don't know what exactly triggered it, but so it's not that, a lot of people see with mast cell dysfunction, it's not like, oh my God, this is another thing I'm going to have to deal with the rest of my life. It often gets better. Usually I go with the antihistamines first and then add cromolyn and some of the other stuff depending on how people do it. But. All right, a couple more.
You mentioned something about fibromyalgia related to.
Well, again, this is just, a couple of decades of clinic experience that everybody I've ever seen with fibromyalgia was hypermobile. And the fibromyalgia people do generally there's a fair amount of literature on that connection. There's literature on autonomic dysfunction in fibromyalgia, the idea of fibromyalgia as a sympathetically maintained pain system. It is central sensitive device over-responding to pain signals. Again, may even tie in with this whole stretch receptor idea that there really are overreacting to pain. But that's, not surprisingly, I've certainly seen people say, well, I have fibromyalgia and I'm not hypermobile because of the basic paradox of hypermobility, that the joint slips and slides around, the muscles around the joint get strained trying to hold the joint together, and the strained muscles tighten up. So there's lots of hypermobile people who say, I'm not flexible, I'm stiff. And unfortunately, if they go to see a physical therapist, again, totally paradoxical, unless the physical therapist knows something about hypermobility, maybe looks at their fingers and says, gee, you're really hypermobile. The idea that there might be under a loose joint underneath all that tight muscle, totally counterintuitive. So I think it's there. There is a little, there is some literature to support me on that one. One more? There is one? Otherwise, they're good. Okay, yes.
Sometimes when I lie down, it almost feels like the bed is vibrating, but my bed is not vibrating. It's me. It's like me feeling that way, but so is that part of this?
Do you get palpitations with that?
I don't feel that I have palpitations,
Okay.
but my heart rate's high naturally anyway
Okay.
for me.
Okay.
So I don't know if that's what's happening, but
Okay.
I just know I lay down and we have one of those beds that do vibrate. And I'm like, okay.
You're sure the bed's off? Right?
Yeah, I'm like, is the bed vibrating?
Yeah.
I press the button and it is, it's me.
Yeah.
So is that?
Well, one thing I think of is that there are people who, if this happens as soon as you lie down, that your heart rate will naturally go up. It's actually the opposite of being lightheaded when you stand up. That when you lie down, there's a sudden increase in blood flow to your brain. Your body says, uh-oh, we better slow things down. You slow things down too much, and then you overcorrect. So people say, so I have trouble falling asleep because I get really anxious at bedtime. If you're not anxious, get into bed. As soon as your head hits the pillow, you feel anxious. That's autonomic. That's not anxiety. Okay, thanks. Appreciate your time and attention.